when we're looking at the immune therapies, first I think it's a good idea to think about what's the normal immune system. And you want your immune system to turn on when there's an infection and to turn off when that infection has been taken care of. And you want actually a pretty short burst of immune activity. Otherwise, you'll be at risk of a whole host of other problems that we generally call autoimmune disease, that your immune system is fighting your own body, and you could get arthritis or skin problems, kidney problems. In general, the purpose of these immune checkpoint inhibitors is to prevent that by having your body tell your immune system enough time to turn off. And in general, that happens by when a lymphocyte is attacking your own body cells, those normal body cells upregulate this turn-off signal called PD-L1. And so tumor cells, now looking at the cancer side of this, tumor cells hijack that system by upregulating PD-L1 even higher in some cases, and that actually kills the white cells that are trying to kill the cancer. There's really been two great revolutions in lung cancer in the last few years, and one of them is our increasing ability to target certain mutations. The other great development is immune therapy, and this really came as a great surprise and excitement to lung cancer doctors. We had little suggestion that immunotherapy was going to be effective here until a new group of immune therapies came to the clinic. In the past, we've looked at vaccines and other ways to sort of juice up the immune system, and it hasn't particularly worked. What we found here is that blocking what we call an immune checkpoint allows the immune system to be activated against a cancer. The most effective way to do that in lung cancer so far is to attack an interaction between a molecule called PD-1 on white cells, lymphocytes, which interacts with another molecule, PD-L1, that can be on tumor cells. And drugs have been developed to inhibit both sides of that. MK-3475 is a PD-1 inhibitor. It's given intravenously, and again, the purpose is to block these turn-off signals. We so far believe that tumors that express the other side of the equation, the PD-L1, that they're the ones that are sabotaging the system, that are hijacking the system, and that those are the situations where blocking PD-1 may be most effective. A lot of work is going on in this area in multiple different trials, and I think we're still learning what are the most important pieces of data to collect. It doesn't matter what was present years ago, or do you need to know PD-L1 at the time that you're initiating the treatment? There are different antibodies, different tests that people are using to look for PD-L1. We don't know which is the best yet. And perhaps the most important question is, what cutoff do we use? Is just a little PD-L1 expression important, or do you need to have a lot of PD-L1 expression to be important? And that's a very important question. You'll see, as I explain some of the data, looking at all of these drugs across the board, there's about a 25% response rate, meaning that if you treat all of your lung cancer patients, about 25% will have major shrinkage. If you try to enrich for people that are more likely to benefit by looking at PD-L1, that number may go up to 40%, or it may go up to 65%, depending on how strictly you want to define PD-L1 expression. At the same time, you don't want to define it so strictly that you don't treat people that could have had a possible benefit. A lot of people are thinking that in the next 5 to 10 years, immune therapy is going to be a major and central focus to our cancer therapy. And I think what we're going to be looking forward to figuring out is which are the patients that are going to benefit from the treatment we have now, which are the patients that are not going to benefit, and how can we augment the benefit for those patients. It could be that giving an immune therapy with chemotherapy might be helpful. It's possible to imagine that the chemotherapy could shrink the cancer and give you time to develop an immune response. It's also possible that adding an immune checkpoint inhibitor like MK3475 to another type of therapy like a more conventional vaccine or what we might call cytokine therapy to otherwise upregulate the immune system might be enough to tip the balance. There's some thought, some suggestion that the immune checkpoint inhibitors are good at augmenting or amplifying an immune response, but they're not great at initiating an immune response to the extent that we have now. So if you can somehow, perhaps with a vaccine, for example, initiate the response and add to that an immune checkpoint inhibitor, we might be able to help more than that 25% of all of lung cancer patients.